Well, despite my rather splashy title, pardon the pun, I can say that I have no disclosures and that at least no pericardia were intentionally hurt in the making of this presentation. So this is clearly a G-rated performance here. So I think we've already heard quite eloquently from Dr. Hoyt and others that the pericardium is a sac, a space, at least a potential space, that is limited superiorly by the adherence and reflections of the visceral pericardium reflecting onto the parietal pericardium. And there are, of course, not only the free pericardial space, but also the sinuses that were well described and form areas where pericardial fluid can collect. As Dr. Hoyt already mentioned, the pericardium is really a potential space in normal individuals. There is up to 50 milliliters, but typically 15 to 30 milliliters of pericardial fluid, which may be noted if you look very carefully in the AV groove or sometimes in the interventricular grooves on short axis. Intrapericardial pressure normally varies between about -5 millimeters of mercury during inspiration to +5 millimeters of mercury during expiration. In addition to inflammatory pericardial thickening, there are numerous disease states which are associated with the accumulation of varying amounts of fluid within the pericardium, creating what is known as a pericardial effusion. In these cases, the pericardial space is no longer a potential space, but rather a real space and a fluid-filled one, and this has consequences. So what are the goals of the echocardiographer in the evaluation of the pericardial effusion? Well, several questions must be answered. In simplified version, how big is it? Where is it? Is it circumferential, or is it loculated or localized over one area of the heart or the other? What does it look like? Does it look like it's free-flowing, or is there debris or other material inside? Most significantly, is it causing a problem? What is the hemodynamic significance of the effusion? And if so, is there anything we can do about it? And echo forms an important component of all these questions. In terms of sizing, small pericardial effusions, typically less than about 100 milliliters in size, are characterized by a predominance of the fluid collection posterior to the heart on parasternal long and short axis views. The diameter of such effusions, when measured from visceral to parietal pericardium, are typically less than 1 centimeter in these views, and there is usually little fluid noted anteriorly in the parasternal views, nor laterally or apically in apical views. Moderate pericardial effusions of 100 to 500 cc's of fluid are typically measured between 1 and 2 centimeters in diameter. We can see here that in addition to a posterior component of fluid, there is an anterior collection noted, and now in the apical views, we can actually see fluid lateral to the right ventricle, posterior to the right atrium, etc. Large pericardial effusions, typically greater than 500 milliliters, show marked increase in the pericardial free space, greater than 2 centimeters at end diastole. With large amounts of pericardial fluid, the heart may swing from side to side during the inspiratory cycle, resulting in alternating QRS on the surface EKG known as electrical alternans. And we can see here as the heart swings, the QRS morphology varies from beat to beat. Accumulation of pericardial fluid in the, quote, closed space of the pericardial sac ultimately results in a progressive increase in intrapericardial pressure, as Dr. Hoyt has already shown us. This increasing pressure results in compression of cardiac chambers and ultimately inhibition of normal filling. We can see here the nonlinear relationship of the increase in pericardial pressure. Ultimately, as the pericardial fluid accumulates, it exceeds right atrial pressure, right ventricular pressure. It inhibits filling of both right and left ventricles, and there is progressive decrease in cardiac output and decrease in mean arterial pressure, characteristic of clinical tamponade. Tamponade has traditionally been thought of as a clinical diagnosis with compromised output and decreased blood pressure. The issue, however, is that the classic findings such as Beck's triad of hypotension, elevations in central venous pressure, and muffled heart sounds really represent a very late stage in cardiac tamponade, and these are seen only in about 20 to 30% of patients. One must also be alert to associated symptoms such as dyspnea and tachypnea, significant tachycardia, and pulsus paradoxus, which is a paradigm of ventricular interdependence and is characterized by a decrease in systolic blood pressure of greater than 10 millimeters with inspiration, 10 millimeters of mercury. What we need to remember is that a large number of patients may present with pericardial effusion. Not all of these have hemodynamic compromise, not all of these have tamponade. A smaller percentage have early hemodynamic effects of pericardial effusions. A much smaller group have actual echo criteria for tamponade, and within that group, a much smaller percentage have actual clinical tamponade. And we need to use our echo expertise to differentiate among these various stages of pericardial effusion. As has been mentioned previously, effusion size does not automatically correlate with the presence of tamponade. The pericardial space is relatively non-compliant, and if there is an acute increase in even small amounts of pericardial fluid above 50 cc's, we can exceed 10 millimeters of positive pressure in the pericardium with relatively small pericardial effusions, and tamponade may ensue relatively quickly. With chronic effusions and slow accumulation, there is an accommodation and an expansion of the pericardium, as was very well described, and larger pericardial volumes may be accommodated, and it may take much longer for the intrapericardial pressure to exceed 10 millimeters of mercury, and tamponade may actually occur at much larger pericardial effusion size. So always be cognizant of that fact. Numerous echocardiographic clues exist for the diagnosis of tamponade or near tamponade physiology, but I think the most recent guidelines, which have already been discussed, for multimodality imaging really put the approach to tamponade quite eloquently. And what we need to focus on are some of the primary echocardiographic findings to raise our alertness to the potential of the presence of tamponade. Obviously, these require the presence of some degree of pericardial effusion, be it small or large. But a paradigm which really should tip you off is distension of the inferior vena cava and the hepatic veins, as well as a marked decrease in the collapsibility of the inferior vena cava, which is pathognomonic of the venous plethora that occurs due to the elevated filling pressures when tamponade or near tamponade is present. Another easily noted abnormality is reduction in LV dimension, both end-diastole and end-systole, as well as indications of reduced stroke volume correlating to the decreased cardiac output due to decreased left ventricular preload. Other classic findings that we typically discuss regarding tamponade can be used as confirmatory findings, and these include right atrial and right ventricular diastolic collapse, the inspiratory bulging of the ventricular septum, which we've already heard about in both prior lectures, which is a sign of enhanced ventricular interdependence, as well as the exaggerated respiratory variation of mitral and tricuspid flow velocities. So I've already described how we look for a pericardial effusion, so we've noted its presence. How about the inferior vena cava size? Well, normally the inferior vena cava is less than 2.1 centimeters in diameter, and it typically collapses more than 50% during inspiration. In this patient, where we can see a very small pericardial effusion on this subxiphoid view, we see that the inferior vena cava is normal in size and is collapsing quite well with respiration. In this situation, we can be pretty confident that tamponade does not exist despite the presence of this pericardial effusion. Compare this to this patient with a slightly larger effusion, where the inferior vena cava is dilated and fails to collapse virtually at all with respiration. This finding raises the observer's suspicion for tamponade to much higher levels. And with this degree of plethora, tamponade physiology, or at least near tamponade physiology, is virtually guaranteed. While decreased chamber size of the LV may be seen in any view, such as this apical four-chamber view, the short axis view in the parasternal really highlights the small end diastolic and end systolic size of the left ventricle, as well as an apparent thickening of the myocardium due to the collapsed nature of the surrounding myocardium. RV diastolic collapse is sort of a classic finding. This occurs during early diastole when RV pressure drops during relaxation. And although collapse may be seen on typical moving 2D images, the greater temporal and spatial resolution of M mode, and I may mention this for those people who cling to M mode preservation, the greater allows really more clear definition of the timing and extent of RV free wall collapse. We can see here that RV collapse occurs at the very earliest part of diastole, shortly following the T wave. Something that's important to recognize is the fact that the longer the duration of RV collapse, the more the hemodynamic significance of the pericardial effusion. Indentation and collapse of the right atrium typically begins at the earliest part of systole, just after the R wave. And again, duration of indentation is significant. If RA collapse extends more than 1/3 of diastole, this is a highly sensitive and specific sign that tamponade may be present. We've heard a lot about the interventricular septal bounce. Because the left ventricular heart preload and filling decreases dramatically with inspiration during tamponade, the septum typically shifts during inspiration with a decrease in LV size and an increase in RV size, and then recovers to a more normal relationship with expiration. And this can be, again, well seen on M mode, as seen here from Dr. Klein's guidelines. Exaggerated respirophasic variation is another classic finding that helps us to determine the hemodynamic significance of the pericardial effusion. Normal respiratory variation of inflow across the mitral valve is typically less than 5%, decreasing during inspiration and increasing during expiration. However, when greater than 30%, as noted in this example, this is consistent with the potential of tamponade. Across the tricuspid valve, where less than 15% variation is normal, 50 to 60% variation suggests tamponade. By convention, we measure the peak E-wave velocities when making these comparisons. but one can look at A wave velocities if only the A wave is obvious. One has to watch out for potential fake outs. In states of hypovolemia, tamponade can occur with even very little pericardial fluid and very minimal elevations in intrapericardial pressure. Regional tamponade can occur with localized or loculated effusions. In severe pulmonary hypertension or RVH, there may be no right-sided collapse, and septal mounts may or may not be present. We've decided that we have a tamponade, we have a large effusion. What can echo do for us in terms of guiding therapy? Well, use of echo really has been demonstrated clearly to avert significant morbidity and mortality in percutaneous pericardiocentesis, either by subcostal or parasternal approaches. Clearance for TAP is generally defined as greater than 1 centimeter at end diastole, and we can see in this example we have adequate clearance from the subxiphoid approach. Whereas here at end diastole, the right ventricular wall abuts the parietal pericardium, increasing the risk of ventricular puncture or tear when inserting a needle or catheter. Echo-guided pericardiocentesis can include infusion of agitated saline to confirm placement of the catheter, the drainage catheter, in the proper position in the pericardium. Here we see a well-placed catheter, or it may confirm perhaps a poorly placed catheter. Oops. Simple pericardial effusions are typically circumferential and echolucent. However, more complex or chronic effusions may demonstrate varying degrees of echogenic deposits, which may be consistent with fibrinous debris, hemorrhagic, purulent, or neoplastic deposits. Determination is frequently not able to be made based on echo appearance alone, and really depend on the clinical situation of the patient. As mentioned, loculated effusions may cause compression of cardiac chambers in a very localized fashion due to otherwise adherence of the pericardium in other situations. So always look in multiple views. As noted, epicardial fat is quite common, and one can differentiate epicardial fat from a consolidated pericardial effusion via its gelatinous appearance and its movement with the visceral and parietal layers of the pericardium. To close, one also needs to differentiate pleural versus pericardial effusions. Here in this patient with a large pericardial effusion and a left pleural effusion, we can see that the pericardial effusion traverses over the descending thoracic aorta and exists behind the left atrium, whereas this left pleural effusion stops at the level of the descending thoracic aorta and the spine. A right pleural effusion can also be seen. This is a patient with a very small pericardial effusion, but a much larger right pleural effusion. And ascites in the subcostal view should also be attended to. So in summary, pericardial effusion requires a thorough echo evaluation with complete 2D and multiplane evaluation to define its location, size, and character. Doppler assessment of the hemodynamic significance through the mitral and tricuspid inflows are important, but especially an assessment of the IVC size and plethora. Septal bounce and exaggerated respirophasic variation are pathognomonic signs of tamponade and of great importance. I thank you for your attention.